Right. So the concept of heart failure with preserved ejection fraction is by historically an old perception, but it's been renamed for about 20 years back. Now, I have, I have renamed this talk in line with what I was told to make it for the non-cardiologist rather than making it too technical. Let me begin by creating a controversy that heart failure is not a disease process. I'm sure most of you would disagree with me at this end. However, if you look at all the cardiovascular risk factors which exist all across the board, you have hypertension, you have got diabetes, you have got coronary artery disease, et cetera, all of these risk factors ultimately lead to the development of coronary artery disease and in fact, future on lead to development of heart failure. And you have stuff like ischemic heart disease contributing to the most in development of cardiovascular disease and so on and so forth. Now, the development of heart failure, therefore, is based on not one etiology. It's based on either hypertension, you have to have either a arrhythmia causing it, like atrial fibrillation, things like left ventricular hypertrophy or ischemic heart disease. The end point of all of these disease processes is the patient gets heart failure. Now, heart failure, therefore, is the end result of many cardiovascular, cerebrovascular disease processes. And that's why I say heart disease or heart failure is not a disease. Heart failure is, in fact, the end result of a poor management of the disease. And that's where heart failure with preserved ejection fraction sits in. Now, the incidence of heart failure across the board, no matter which type of heart failure, is increasing as time goes on, and with age, it moves on. Men are more affected than females, and this process also reflects on the prevalence of coronary artery disease and heart failure that increases with age. Men get more affected than female patient population. Not only heart failure itself, but other risk factors too. But every time a patient gets admitted to the hospital, their survivability drops by 1/3 after admission. So by the time the patient is discharged from the hospital, on the 4th admission, the palliative care team kicks in. This is how bad it is. And despite our advances on device developments and disease-modifying drugs, the median survivability of heart failure still remains at 3 years from diagnosis. So pretty slow in respect of all of the other processes that are going on. But how do we confirm the diagnosis of heart failure? Now, diagnosis confirmation based on the time-honored acronym of CPBE. CPBE stands for clinical, which is evaluating the patient before you do the tests on the patient. This is by far the most important thing from a clinician point of view, that you have to have a proper history, symptom evaluation, and evaluation of the signs. From a clinician's point of view, symptoms are evaluated by the Heart Failure Association NYHA scoring system. NYHA is normal patient, no symptoms at all. Class 2 is minimal symptoms on maximal exertion. Class 3 is maximum symptoms on minimal exertion. And class 4 is symptoms at rest. All your class 4 symptoms should be admitted to the hospital. And the evaluation within this history taking is that you have to evaluate things like evaluating the presence or absence of comorbidities, because each comorbid condition leads to increased mortality within the patient. And within that, I have highlighted atrial fibrillation, because atrial fibrillation is one disease process which begets heart failure, and heart failure begets atrial fibrillation. The moment you develop atrial fibrillation, you lose 30% of the cardiac output. So the figure 30 is very important in the management of atrial fibrillation. After this, you look at the preliminary tests. And these are not any fancy tests. These are tests like doing bloods to rule out any reversible cause of heart failure, like anemia, infection, inflammation, looking at ECGs of the patient, looking at the chest X-ray. This is even before you start doing fancy echocardiograms or dynamic analysis. Now, the third part of it is what we call the BNP. And I'm sure you guys are very, very familiar with that. What does BNP mean? BNP has a negative predictive value. This is such an important factor that I can't emphasize it more, that this is not that the level of BNP or the presence or absence of BNP. If you have a negative BNP, it rules out significant cardiac failure. So whenever a patient comes in with non-acute heart failure, you evaluate the patient, you do simple tests, then you order a BNP. If the BNP is abnormal, that patient needs further testing. If that BNP is negative, you can discharge the patient that this is not heart failure, but look at any other cause of shortness of breath. A virtually normal BNP rules out significant heart failure itself. Every hospital, every trust, every country, every lab has different values of BNP, and hence don't go by what these values are depicted. The third and the last one in evaluation is your echocardiogram. The echocardiogram, a simple echocardiogram looking at the left ventricular ejection fractions, looking at chamber sizes, and looking at the valves. Nothing fancy at all. So these are the 4 things that everybody needs to do before confirmation of heart failure. Okay. Now comes ejection fraction, the bane of a cardiologist. You must have heard ejection fraction is 60%, 40%. What does that mean? Why aren't our ejection fractions 100%? Surely 100% is better than 60%, but why is that so? In order to understand that, let's look at the continuum. You have to have a normal lung, you have to have a normal heart, and you have to have a normal kidney to make sure that your cardiovascular system is working well. You have to ensure the integrity of the heart muscle is good, and only then you can predict that the heart's performance is good. Now, a normal heart receives blood from the body, from the lungs, and ejects blood. Unlike what many of us think, the heart is never without blood. Even after systole, there's about 50 ml of blood left in the heart, and this is called residual blood volume in the left ventricle. This is called end systolic volume. Now, end systolic volume will remain as end systolic volume when the heart contracts, because the heart can't contain air. Now, let me park it on this side and take you further on to a concept of stroke volume. So first of all, heart is never devoid of blood. Number 2, 50 ml of blood should always be at the end of systole. The stroke volume is the volume of the blood at the end of systole subtracted from the volume of blood in diastole, and that gives you a stroke volume of 70. So no big math about it, simple equation. Now here is where the stroke volume converts into ejection fraction. Ejection fraction is the amount of blood ejected from the ventricle over the total amount of blood in the ventricle. And if you do a formula, which is stroke volume over left ventricular and diastolic volume into 100, that's what gives you ejection fraction. Let's do a math. The formula is right at the top. We already know what the stroke volume is, which is end diastolic volume minus end systolic volume. Let's apply that. That's the stroke volume. Let's apply the end diastolic volume, which is over here. Do the math, divide it by each other, you get a figure of 0.58, multiply it by 100, and you get a magical figure of 58. This is your normal ejection fraction. And that is why the ejection fraction is always around about 55 to 60. And that is how we measure the performance of the heart, not at 100%, but in percentages below 60. A dilated heart has a high end systolic volume because it can't pump all that blood out, and therefore the more dilated the heart, the more poorer the performance and lower the ejection fraction. Now, ejection fraction translated is that a normal ejection fraction is primarily that the patient can do whatever he likes without any problems. A moderately reduced ejection fraction, he gets minimal symptoms on maximum exertion, which is NIHA class 2. The class 3 is when you get maximum symptoms of minimal exertion when the patient is at rest or going through the activities of daily living. A normal heart transforms into a dilated heart, and the process by which it happens is Either you have a problem with the heart muscle itself, a problem with the lungs, or problem with the kidneys. Now, let's see. The heart muscle becomes weak. It's trying to squeeze all that blood out of the heart. The brunt is borne by the lungs because that's the back chamber. And that's why every patient with heart failure gets basal rolls, gets fluid uptake in the lungs. Now, a dilated, poorly contracting heart, which is unable to eject over and above the systolic volume, which is 50 ml, leads to heart failure with reduced ejection fraction. This is where the term comes, reduced ejection fraction. Now, if you compare a normal heart echo to an abnormal heart echo, you can see that the left ventricle over here is contracting very well. Over here, it's like a globally hypokinetic, like a balloon shape, but not squeezing very well. This is heart failure with reduced ejection fraction. Okay. Now, before 2000, we cardiologists were very happy. We were enjoying the sunshine. Every patient with heart failure, we knew it for sure that when we examine him, the patient is going to have a problem with the heart leading to heart failure. Has had a heart attack, or has had a valvular problem, etc. At the moment that we see a failing heart, we can predict that the left ventricle will be impaired for the heart to fail. There is no echo report which is going to tell us the heart is normal, but the patient is in heart failure. By the year 2000, we're getting reports that patients were having hypertension leading to heart failure, etc. The hearts were not dilated, and we termed that as diastolic cardiac problems. However, the definition till year 2000 was always a dilated heart reduced to reduced ejection fraction. So life was very simple for us. But as the advances in cardiology occurred, more and more echo machines were distributed. A syndrome was beginning to occur in which patients who had normal heart sizes were coming in with heart failure because of the sheer number of the epidemic of heart failure. And the year 2001, the whole world changed. The whole world changed to a point of no return. This is not because a monkey was given the codes of the nuclear button, but a formal diagnosis of heart failure due to a diastolic dysfunction was first reported in JACC 2000, that now we recognize the heart failure can exist even in the presence of a normal ejection fraction. Before that, there were reports of diastolic dysfunction, but it was the first time this was reported that yes, you can have preserved ejection fraction. And the problem starts from the periphery rather than the central. It was thought that initially that heart failure with HFrEF was a central problem leading to heart failure peripherally. In HFpEF, it was thought the problem started peripherally and converged centrally. The special patient population which came forward was which had left ventricular hypertrophy due to any cause, maybe hypertension most probably, obese people, people with obstructive sleep apnea, people with atrial fibrillation and left atrial enlargement, who are predominantly, I'm sorry to say, females, and hypertensive patients. So this was a patient population which was coming along. Now, this is myself in 1995. Dr. Azizur Rahman may remember me, was doing the bodybuilding, and I was very keen to build up my muscle. And I, in fact, participated in a few programs too, but that never worked out, and hence a cardiologist. What I realized that the more weight I picked up, the more muscle I built. I was not growing more muscle, but was the same muscle which became thickened. And this is called hypertrophy. In the heart too, the more load or a pressure is on the heart muscle becomes thick. This is called left ventricular hypertrophy, not left ventricular hyperplasia. There's a difference. Now, what does that mean? Now, look at a cross-section of the heart on an echocardiogram. You can find a normally contracting left ventricle to a ventricle which is thickened and non-compliant. So there's a difference in the thickness of the muscle of the heart. Now, in order to look into it more carefully, imagine that a muscle becomes thick. There is a fundamental change in the nutrition of the muscle which is required to make the muscle work properly. The muscle becomes thick, but the blood vessels don't grow appropriately to feed the muscle. That means the muscle becomes larger, And there are areas of the muscle which do not get that same blood supply which they used to before the muscle became thick. Now, with that, what happened was the heart muscle became large, the heart muscle became thick, and because of that, during systole, as we know, no blood supply occurs. During systole, blood supply was not carrying on to the heart properly, and the patients developed cardiac failure or ischemic heart disease. The heart muscle was not relaxing properly. And this is when we call heart failure with preserved ejection fraction, when the heart does not relax properly. Relaxation is a fundamental need of the heart to perform a satisfactory systole. The transition of the heart from a normal heart to a hypertrophied heart leads to certain change of events, both metabolically and anatomically. We have situation in which we can differentiate now very clearly that a dilated heart is significantly different from a hypertrophied heart, yet the symptoms with which the patient presents with are exactly the same. That is why it's very difficult to diagnose heart failure with preserved ejection fraction. The spectrum of heart disease from a normal heart to a dilated heart is called heart failure with reduced ejection fraction. The transition from a normal heart to a hypertrophied heart which does not relax properly is called heart failure with preserved ejection fraction. Now, if you are confused, let me confuse you even more. Now, the thing is that we know that heart failure with reduced ejection fraction, when your ejection fraction goes down below 40%. Heart failure with preserved ejection fraction is that your heart failure, your EF is good, but you're still in heart failure. There's another category which is called heart failure with mildly reduced ejection fraction, which is called HEP-MREF. Wait for it, there's going to be another one coming very shortly. So we have to identify that as time goes on, why are these patients getting ill? Why are these patients getting sick? So the syndromes and the patient population is somebody who's a female, older, obese, with New York Heart Association criteria lurking around class 3 to class 4, more cardiovascular comorbidities like diabetes, atrial fibrillation, which I've just explained to you, more cardiovascular comorbidities and non-cardiovascular comorbidities too. Now, those of you who were trained in Pakistan also know about this book, Bailey Love's Short Practice of Surgery. Now, you remember the time-honored mnemonic of cholelithiasis, right? It's a fat, female, fertile, and 40. Remember that? This is exactly what the patient of heart failure with preserved ejection fraction is. Add to it another thing, that they're suggesting a genetic link to this thing. So it may be in times to come that this is going to come forward. A fat individual, in fact, develops left ventricular hypertrophy either due to the need of the body, hypertension, obstructive sleep apnea, and the same process occurs. The cells outgrow the supply, and that is why these patients die very early. Heart failure with preserved ejection fraction is a problem which starts at the periphery, hypertension, atrial fibrillation, etc., and that's what leads to all this. It occurs in about 70% of the patient, but the main thing is that as time goes on, we are recognizing this more and more. With the result, older patients, female more than males, hypertensive patients, and atrial fibrillation patients are more and more affected. All over the globe, almost half of the patients with heart failure are getting the diagnosis, and the comparison between survivability between HFrEF and HFpEF are exactly the same. So how do you diagnose it? Again, for diagnosis of HFpEF, we go to CPBE, and our chart was very clear that you have got to fulfill the clinical preliminary test, BNP and echocardiogram. However, in the clinical side of things, you've got to add those 5 Fs that I told you about. You've got to add left ventricular hypertrophy, you've got to add atrial fibrillation. In the echocardiogram, we need something more advanced, so we have to add diastolic dysfunction analysis, tissue Doppler analysis, pulmonary hypertension analysis, and dobutamine stress tests also. If nothing works, the patient goes for what we call invasive studies, etc. Now, the diagnosis of heart failure, no matter what, has to have symptoms and a BNP positive and an echocardiogram. In case of HFrEF, you have got to have three things. You have got BNP plus symptoms, sign, and a poor echo. In case of HFpEF, you have got to have symptoms, sign, echo, plus an echo evidence of something else going on. Okay? So this is a standard echocardiogram report, and you all have seen demographics. We're looking at, sorry, let me just go back. That you have weight of the patient, age of the patient, etc. You can interpret straight away that the patient's systolic function is good. We are all very happy. But there's something else lurking over here. You do the measurements. You look at the heart wall thickness, which shows left ventricular hypertrophy. So if somebody is elderly, obese, or has left ventricular hypertrophy, your alarm bells should go on ringing. Something is going on. This is where till you come to the Doppler. And these two values, ELAT and the ELAT prime lat. The next slide is probably the summary of my whole talk. And those of you who have mobile phones, I'd like you to photograph that. That if on an echo report you find this, that means the patient has diastolic or heart failure with preserved ejection fraction. Make sure the report which is generated has those two figures. I'm not going to go into detail because it was deemed beyond the scope of this talk. Now, the formal diagnosis of HFpEF is based on two algorithms. The first algorithm is PEFF, and the second algorithm is H2FPEF. The first algorithm is that P stands for initial workup, E stands for diagnostic workup, first F stands for advanced workup as far as the stress test echocardiography is concerned, and F2 stands for the etiology of that heart failure. Very complex, but let me summarize in a different way. What they did was they did some major criteria and minor criteria. Looking at the function, which is a Doppler analysis, which I've just shown you, E to E prime, morphological, looking at the heart valve thickness, and the BNP, and this is it's very interesting. The BNP values are different if you are in sinus rhythm. The BNP values are different in what you have in AF. In AF, the values should be higher because automatically whenever somebody comes in fast AF, you may have higher troponins or higher BNP. Now, there are some minor criteria. If you have the major criteria is met, if you have got 2 points, HFpEF is confirmed. Minor criteria, more than less than that, you need to do some invasive investigations. But this is the importance of atrial fibrillation, that atrial fibrillation not only begets heart failure, but also causes heart failure too. Remember the figure 30, every patient who develops atrial fibrillation is going to lose 30% of the cardiac output. Do not ignore it. The invasive, fancy studies, we rarely do them, so don't even go there. However, looking at the second variable, which is H2FPEF, looks at the heaviness of the patient, the hypertension, presence of hypertension, the atrial fibrillation, pulmonary hypertension, elderly patient with filling pressures. And the scoring system is very simple. If you have more than 6, your conclusion is that patient has HFpEF. How do these compare? Now, the way they compare is that I personally feel that H2FPEF is a very good scoring system. Don't even go to the first square because it does not help at all. How do you manage? Now, heart failure with reduced ejection fraction has very clear guidelines. They are that you can have suppression of angiotensin, suppression of noradrenaline, suppression of aldosterone. You also have disease-modifying drugs like Entresto, ARNIs, and of late you have substances like SGLT2 inhibitors. All of them have been known to reduce the cardiovascular mortality and morbidity in heart failure. The drug treatment outcomes are very simple, that the symptom relieving is diuretics, non-symptom relieving disease modification are all these agents. And they have been proven over and over again that diuretics have no improvement in survivability, only in the function. Now, what about HFpEF? There have been studies and studies and studies. And I'm going to tell you, not all of them, but a few of them, that whenever somebody gets heart failure, you give them beta blockers. But do beta blockers help in HFpEF? The answer is no. There's no evidence to support it, only if the patient is tachycardic. Next. How about things like angiotensin converting enzymes? The reduction in hospital mortalities and hospitalizations, yes, but again, there's no reduction in the primary outcome. Let's look at the studies like CHARM, PRESERVED, etc. It all showed that primary endpoint was never met. That means, fine, use them, but the evidence is anecdotal. How about spironolactone, eplerenone? TopCat showed that probably in HFrEF, yes, but as far as large studies are concerned, there's no reduction in hospitalizations or mortality, unlike HFrEF where you had 15% reduction. How about things like angiotensin receptor neprilysin inhibitors, which are ARNR or what we call Entresto? Does that help? Well, yes. They have shown there's a composite endpoint reduction in cardiovascular death, but there's a caveat to it, that only the female patient population at 60% got benefit, the males did not. So they had to reduce the age of indication to 40%. As regards sodium glucose cotransport 2 inhibitors, SGLT2, very effective in HFrEF, but as far as this is concerned, it has been shown that once or twice in small trials it has helped. In fact, the Emperor trial, which has just been published, has shown some degree of benefit. Just excuse me for a second. Now, do these medications help? The answer to that is no, not one medication, but all of these medications in combination anecdotally do help. The cardiovascular mortality and morbidity, which HFpEF remains the same, despite our doing things like exercise therapy or spironolactone, etc. Diuretics remain the mainstay of your treatment. I always say furosemide, which trade name is Lasix, is your lifesaver. And we call it Lasix because it lasts for 6 hours. Remember that. That's why furosemide has to be given on a BD dose. Heart failure with preserved ejection fraction has multiple causes, all in periphery. Heart failure with preserved ejection fraction has one target, and that's the whole body. Thank you very much. Heart failure is not a disease, poor management of the disease.